I may request you to please sit, turn off your phones, settle down. Try and sit a little erect, because after lunch we might all sort of fall asleep. That was a good amount of food, and no coffee. I'm Satyanarayana Balsari. I'm faculty in the School of Medicine and the School of Public Health at Harvard. I'm really excited to be with my colleagues here at this panel, whom I will briefly introduce because it'll give you context to who they are and where their remarks are coming from. Mr. J. Satyanarayana is chairman of UIDAI, but he also recently chaired a committee that is envisioning what the digital health data ecosystem of India is going to look like. So we're really lucky to have him here, given what the panel is titled. It was purely incidental that was the title of our panel as well. So great privilege that he's been able to join us. To his left is Professor Dr. Tony Raj, Dean of St. John's Research Institute. He's also head of medical informatics at SJRI. A unique combination and one that we need many more clones of interdisciplinary training, both in the health sciences as well as in informatics. To his left is Rahul Matthan, legal scholar who has influenced and helped shape many policies in India with the central government, and has played a critical role in helping many of us think through the challenges of digital health data implementation in India. And to his left is Sunita Nadhamuni, who has extensive experience working on the ground in rural, remote India, in small town India, implementing large-scale population health projects, both in the private sector for close to a decade and then in the public sector thereafter. She has been instrumental in Karuna Trust's development of their software rollout, and now works very closely with the government of India for their non-communicable disease platforms. That context will give us a sense of where their remarks are coming from. I'm here to talk about big data and artificial intelligence because everyone these days must talk about big data and artificial intelligence. And as you must have realized, big data and AI is going to solve everything, and certainly is going to solve healthcare. How, where, when, and why we seek medicine is going to change in our lifetimes. Algorithms are going to read X-rays better. They might better how we diagnose diseases. They are supposedly going to succeed in figuring out how doctors think, and they might indeed do better decision-making than physicians. A couple of weeks ago, there was an article in Nature that said that in China, they had used data from 101.6 million records to feed machine learning algorithms with really good prediction rates. And so there was even more excitement about what data can do to healthcare delivery. But machines will only be as good as the data that feeds them. The question is, where are these data? In parts of the world where we need technology, where we need changes, where we need to rethink how health is experienced and how health is delivered, there are no data. Think about where your health data are. If at all you do have health data, they are in paper files, in polythene bags, in cupboards in your houses. And if for the same disease you are going between different doctors and hospitals, you have multiple folders from those different hospitals. And if you want to do something as simple as just trend your blood sugars across time, across the lab from Max and Apollo and Fortis, it would entail literally taking all those files and putting them next to each other and trying to look at what is happening to your blood work. And yet, at the end of the year, a music app, Spotify, can very accurately tell you how your music tastes changed during the year and what songs you liked best. Sonos is a speaker that they sell in the United States. I don't know if it has made its way here to India, which will draw your music from multiple different apps, from your Amazon Bank, from your iTunes, from Apple Music. These are large, disparate corporations that have nothing to do with each other, and yet this one app can draw your music from all of these. Who would have thought that these were problems that needed to be solved? And yet our health data cannot be compiled from the various doctors and nurses and hospitals and the multiple touch points in our health ecosystem. There are many people in India. We had a conference, all of us met yesterday from 9 to 5, and there were extraordinary initiatives that scaled up to tens of millions of beneficiaries across the country, where people are working in small towns, in Middletown, India, trying to imagine how we can rethink delivery of healthcare, trying telemedicine, trying apps, trying digitization, putting more data in the hands of Indians. And part of what we were trying to figure out is how do you make sense of all this? How do you actually make health data in India available for research, for clinical care, for the patient, so you solve problems that need to be solved? You know, we started this morning with the statistics where Mr. Khan said, 1 out of every 2 women is anemic, 1 out of every 3 children is stunted. So where do we begin to apply these tools to solve these problems? These are actually very exciting times, because with Ayushman Bharat, you have the potential of now having some kind of catalyst to trigger this digital health ecosystem. You are saying that maybe 500 million Indians are now going to have access to some kind of healthcare, and there will be demand for accountability in delivering of that healthcare. What is also exciting is the jurisprudence that is evolving in India. We've had the Puttaswamy judgment that squarely says that privacy is a fundamental right. Interpreted in the context of health, that would mean the patient has a right to her health data, which means we need to figure out how to put her health data into her hands. So let us think about that patient, that migrant worker who is pregnant and she's traveling across several state lines to work and to seek care. And that'll be the context in which our panel will try and share with you all the developments that they've been working on, and try to examine what the catalysts and barriers might be to stimulating this digital health ecosystem in India. With that, I'd like to welcome J. Satyanarayana, sir, please.
Thank you. Good afternoon. Really, it's a pleasure and privilege for me to speak in a conference on science and society. Basically, I was a student of science myself before getting diverted or hijacked into IAS. I did my master's in solid state physics 45 years ago, and so on. So today, I think what Sachit has mentioned just now provides an excellent starting point for me, that while different efforts are going on across the country, what is the kind of architecture that can bring them together going forward, so that we are singing the same kind of tune? So with that, the paradigm shift is going to happen from building systems, moving away from systems to ecosystems. Today, what we need in India is ecosystems and not systems. Ecosystem thinking is very much required. Health is one of such ecosystems. And the best example today of an ecosystem is around ID, digital ID or Aadhaar. The architecture is so beautifully done by my predecessor, Nandan Nilekani. 10 years after it was done, still it's valid and really state of the art. It's really amazing kind of, it supported a whole ecosystem of 1.25 billion digital ID still counting. So what I'm trying to say, show you is, how do you do similar thing in the area of healthcare? Okay, for digital ID, you have done that. Already you are, it is behind you. How do you create similar thing for health, similar thing for agriculture, similar thing for education ecosystems? So today I'm chairing also this one special expert group on this subject. How does the big picture look like and what does it take? So I will quickly run through this presentation to highlight some of the important aspects. We are about to deliver our report to the Government of India, Ministry of Health, by middle of this month, and thereafter there will be a round of public consultation and so on before we finalize it. So that's why I said it's work in process, but you have the preview of that today here. So this is deriving from the National Health Policy 2017, which was approved by the Cabinet in 2017, because technology or architecture cannot start in isolation on a one-off basis. It has to base itself on a policy. What does the country want? So it is revealed through this policy which says health and well-being for all at all ages, better access, better quality care. Continuum of care is one more concept that has been introduced in that across primary, secondary, tertiary, there should be a seamless, treatment course. And then end of the day, it also spoke about a federated national health information architecture. In a country like India, obviously with so much of diversity and so much of unevenness in the kind of developments, you can't have a monolithic architecture and say, no, it will run across the entire country, which is very difficult. So a federated architecture is what is mentioned in the policy, and also we, as a committee, we felt that is the right way to go. You can't concentrate the whole data in one place or two places. So this is a kind of vision which is, fairly straightforward, that end of the day, we need to achieve universal health coverage while maintaining security, privacy, and confidentiality of the data. But I'll skip through. And this is a picture which shows the way the committee thought through the whole thing in a layered manner, that you start with a vision, you create a set of principles, around that you create some specific building blocks. Building blocks are reusable in the sense that across the country you can, by the service providers, by the insurance companies, by the governments, by the anyone can use those building blocks. So create those building blocks. Don't try to build the Taj Mahal entirely yourself. Create the building blocks for the Taj Mahal. Then put a set of standards and regulations in place. Then obviously the application ecosystem will develop and services will flow out of it. So we have created the whole thing in a layered structure like this, which is a mix of both health domain as well as technology domain is contained in this. And this is very quickly, I will not have time to go through all these principles, but these are fairly generic principles, but very important for everyone to observe. Like rules of the road, they are like rules of the road. If everyone follows the rules of the road, we don't have accidents, right? So similarly, if everyone, the service providers follow the rules of the road, which are called the principles here, it automatically solves a lot of problems in creating that, ecosystem in a faster manner. Key things here are single source of truth about, and absolutely there should not be any gaps, as Sachit was trying to allude to earlier. When you go across different hospitals, they should be able to interoperate and so on. All these principles are there explained in the document. And this is the main slide I would like to spend a couple of minutes on, which is the big picture for the health in the country going to be. So it's a layered architecture. At the bottom we have the infrastructure layer with the health cloud being at the center of the whole thing. And then very importantly, given the kind of dialogue and the sentiment that is around, the sensitivity of health information. So we have created a new concept of Privacy Operations Center, POC. We have heard of NOC. We have heard of SOC, security. operation center. So, to increasing importance being given to privacy, you said, let there be a 24/7 watch on whether the privacy is being respected by all the players, right? Public or private. So a POC is a new concept that I would like to point out here. Then above that, a set of data hubs which takes care of all the master data and the patient health records, PHR, or aligned to EHR. Then to enable information to be exchanged by various players, HIE, and analytics, which is again becoming very, very important, then a set of applications around wellness, around emergency, about healthcare proper, public health, and medical education. Last, topmost layer is the access layer, where through multiple channels, public and citizens can access their own records, subject to the consent. One important thing here is also consent. You have to take the consent of the concerned person before you can allow anyone to use that data, even for clinical purposes. So the consent manager is one component, anonymizer is another component. These are very important in the current context of India. Right from the beginning, you design the system which has privacy inbuilt through its components and its building blocks. So secure by design, private by design. That is what we have attempted here. Then this is a list of services. I would not like to, I think the conference proceedings will have this presentation, you can see that. So what are these benefits from different stakeholders' point of view? What are the services that they will get? I have listed out here in this particular slide. There is something for everyone here. Each category of stakeholders, like citizens, like health service providers, like support service like insurance and technology service providers, IT, and so on. These are the standards recommended there. One thing I would like to mention here is the standards in health area are so voluminous in size that we have to cut it to our requirement. We have really mercilessly removed a lot of standards which only add to the volume and burden of the clinicians. So bare minimum, the minimum viable set of standards we have recommended to start with. We have countries which started with big, very ambitious standards. They have taken 2 decades to reach wherever they are today. So learning from that, we put it to the minimum required standards here. Then lastly, the report also has a discussion on the personal health identifier, Aadhaar, non-Aadhaar based. How do you manage the situation which is within the conformity of the law of the land? Then also we have learned from what mistakes have happened in big countries elsewhere, and then we have said that everyone should avoid these kind of problems like incorrect identification, incorrect medical history, incomplete history, gaps, incorrect lab reports. How do they creep into a system? Then it will vitiate the whole concept of health for all and continuum of care. So these are very important to learn from these lessons. And also one thing is avoid electronic paperwork, physician burnout, as it is called in the US. So we are hard coding all these things in the report itself so that they're going to design. And then also an institutional framework, and we also created an action plan. It's not merely, sorry for saying, but a theoretical kind of work, but an actionable report. So there are about 27 actions here which come out of this report. Some of them are immediate, meaning within 6 months they shall be completed. Some of them are short term, 6 to 12 months, and remaining medium term, 12 to 18 months. So there are 27 actionable points which arise out of this report. If you are able to follow it systematically, I think this is going to be the largest and the best and most comprehensive health system. We have studied the systems of several countries, including UK and USA, before we have made these recommendations. Hope that this will be a game changer in the next 12 to 18 months, I suppose. And thank you very much.
We are going to facilitate a dialogue between the panelists. Since there are no more presentations, we'll remain seated. Thanks.
Good afternoon, everyone. Pleasure to be here. So my name is Sunita Nadhamuni. We are a technology partner to Government of India working on Ayushman's Bharat, the NCD program, non-communicable diseases. It's one of the largest programs under the Ministry of Health and Family Welfare. Very forward-looking, progressive program, looking to screen every individual over the age of 30 for 5 diseases: hypertension, diabetes, oral, breast, and cervical cancers. Probably one of the largest ones in the world, and the aim is to be fully IT enabled, and so we are the technology partners providing that. The person from the ministry who heads it, Mr. Rajiv Kumar, is sitting right here too. And this is a Dell Csr Initiative, another innovation in itself, because Dell decided to say that CSR doesn't have to be just giving laptops and planting trees. Let us actually provide a team that can help build the software for important social causes like this. So that's something that we're very proud of. Our technology, we've been doing this for the last 5 years. We started first with an NGO called Karuna Trust, which is important because we've co-created it with the actual users in a very small scale. We then worked with government of Andhra and did a statewide program where which targeted 7 million women over the age of 30 to be screened for these things. These numbers are enormous, as you can see, right? Then we worked with the state of Telangana, and that project is going on still. We started working with Government of India in a year and a half ago, right? So in this journey, we have spent an enormous time. I personally have interacted and trained more than 500 ANMs. ANMs are health workers, and a smaller number of doctors and health staff. So what I want to talk about today is about implementation of large-scale health IT programs, right? Some of the insights and our experience that we've gathered. And so there are 3 points here. One is the ecosystem readiness, which is very critical before you launch a program like this. Second is the focus on implementation. And the third is looking ahead, right? What are the things that you need to focus on? So, just to say where we are first in the context of health IT in the country, there are enormous. The National Health Portal lists 75 mHealth apps, right? 75 that are listed. So there are probably hundreds, if not thousands, already out there that are, and this is I'm talking in the government space, right? That are being used for as pilots on a much smaller scale. And these go, whole range of use cases from tracking immunizations, health promotion apps, SMS-based services, personal health records for patients, teleconsultation, telemonitoring, telementoring, skilling, the whole range of them out there, right? And what do users, at least in this level, when we say mHealth, usually they're for the health workers, the last mile, or as some people like to say, the first mile, the people who are closest to the citizen. These health workers, in general, they have been very positive about the use of technology. Many have said that it reduces, because they have a huge burden. We did a time and motion study and found that they spend about 2 hours a day in actually doing paperwork. Just to understand the scale, there are 200,000 ANMs in the country and 1 million ASHA workers who are the community workers. And they are, an ANM on the average has anywhere between 35 to 40 registers with a total of about 600 data fields, right? That's the amount of data and the amount of paperwork that she needs to do, right? Both an opportunity and a challenge and an opportunity when you go digital. So the overall response from the health worker angle has been pretty positive. They like the ability to be able to quickly pull up data, to quickly fill out their reports if they still need to, and to be able to, when asked for any information, they're able to quickly find that. They also, actually, some have said that they get more respect when they walk into a village, because they walk into the tablet and suddenly they find people are a lot more receptive and look up at them with more respect. So, so that's where it is. Where I think evolution hasn't been strong enough in the government space is in the doctors, right, in the higher levels of care. You digitizing at that level, right? So going back to what are the three main points, right? The first is ecosystem readiness, right? So the first mHealth pilot that started 15, 20 years ago, health workers were using these PDAs and so terrified about using it that they would just keep it locked up, right? 3 years ago, when we started working with government of Andhra, the CM Chandrababu Naidu had said that I will not allow you all to launch a health program if I don't have real-time dashboards along with it. Real-time dashboards meaning data should have been collected digitally on the ground and feeding into dashboards. And since then now that's become the norm. Every state has their CM dashboards, which where they're monitoring on a daily basis. Government of India under Ayushman Bharat Health and Wellness Centers, there are 12 packages. This is one of the spokes. IT is one of the spokes in health and wellness centers. Budgets allocated. So we have an opportunity because the time is right now, right? The time is right for this. In terms of digital infrastructure, Mr. J. Satyanarayana just talked about it. When the National Health Stack, when this is announced and actually operational, it'll be so much easier. That'll give a big impetus to the whole ecosystem in terms of app development and things to build on, right? And in terms of the importance, I think there's a very strong acceptance and understanding of why we need to go digital, right? In terms of, statistics, numbers, but also in terms of people who are working in health and are looking on a daily basis at the challenges being faced due to poor awareness of, poor health-seeking behavior, low levels of screening. It turns out that, women between 15 and 49, single digits, some actually just low double digits, right? 11% have been screened ever for breast cancer, right? So these, and this is one of the ones that's most preventable and gives you best health outcomes if it's caught early. So given all of this, there is an, acceptance that technology is an enabler that will help us address some of the challenges that we have today in terms of getting people to be screened, followed up for chronic conditions, make sure that they get the proper care, they're adhering to that care, and having, technology that enables all of that is a good thing, is well accepted, and there is a readiness for adopting that, right? And so given that ecosystem readiness that we have out here, the point is that this is a really good time for large-scale implementation programs, because there have been enough pilots that have been done, and those pilots have succeeded, and now the ministry and the state governments are ready to take it forward. So that was my first point. The second point is technology is just one small part of it, right? When you actually get down into implementation, there are enormous numbers of challenges and things that need to be put in place for these implementation to succeed, right? So talking about some of these, first thing is in the design of the apps or solutions that you're doing, right? Has to be user-centric, and that can't be emphasized enough. We spent the whole day yesterday talking about this, and pretty much every presentation was saying the same thing. It has to be user-centric, it has to be co-created with the user. Exceptions are the rules. So when you're talking about these for different states are going to have their own protocols, they're going to have their own infrastructure set up. So you need to have solutions that are flexible to the different needs of diverse users. You need to have systems and processes in place for dealing with all the logistical issues, mobile number change, OTP failed, all of that stuff. And then you need to have enough support to make sure that the experience for the users is good, right? Network connectivity. Everywhere, even in Vigyan Bhavan, we have issues with network connectivity. This is massive deployment activity. So you need a lot of support at various levels to make sure that adoption is smooth, right? So this implementation from all levels, is really critical to make sure that these things succeed. And the final point that I want to end with is what we need to focus on looking forward, right? Given that there is agreement, there is ecosystem support, readiness, and implementation, what we need to do is interoperability, right? Because of all of this, as one person like to put it, there is a tsunami of applications out there, right? 100, Maharashtra I think had like some 40, 50, and I don't know who's counting anymore. There are enormous numbers of applications. They don't talk to each other. You have all the data in silos. So now it's actually worse for the health worker who has to enter it in multiple applications. So interoperability is urgent, and and the health stack will really help us. Moving to that health stack will make this, is very, very critical. And the second is skating to where the puck is going, right? We are, we're just talking over dinner. We have to move away from traditional EMRs and, look at, trying to get the doctor to enter these EMRs is going to be very challenging when they have to be talking and engaging to a patient. So you ideally want, you want to use AI, you want to use voice-based NLP apps that will allow them to just talk while they're giving care to the patient, and then let that be, generate a health record. So yeah, that's what I'm going to, ecosystem readiness, implementation, and, looking forward to emerging technologies. Thank you.
Thanks.
Good afternoon. It's a pleasure to be here. I'd like to thank the organizers for inviting me over. Thank you, Sachin, for that introduction, and thank you, Mr. Satyanarayana, for giving that wonderful pitch to let us know that the government is thinking strongly of a national digital health mission. I think this is so important to have direction in this area. I come from a background of a medical school. I teach as a professor of physiology in St. John's Medical College. I dived into research about 20 years ago, and from there rolled into medical informatics about 18 years ago. I've been driven by this whole fact to connect the dots. We have data lying in different areas. So I'm going to give you a perspective which is very different, but from an academic background and being in research and actually driving some of the IT initiatives, I'll give you a background, a perspective in that way. We all are aware that technology is rapidly accelerating. Many of the speakers and panelists just spoke that yes, there's so many things happening. There are so many apps. But the barriers exist, and these are several barriers which I'll list out in a short while. AI, as Sachin mentioned, the data that we collect drives AI. And the biggest challenge we've had is quality of data. How do you get the right data? How do you clean it? And in our country, we have volumes of data. Yesterday at the conference, at the workshop, it was so exciting to see several groups, as Sachin mentioned, doing some fantastic work. All of them collecting data at the granular level, at the grassroots level. But again, the discussion came about how do you connect your data? And there are challenges there as well. So let's look at some of the catalysts. In spite of all these changes are happening, we are not comparable to banking. Today, I don't know how many of you use a UPI app, which is fantastic. You can actually transfer money from your phone to any other app in a millisecond. It's so precise. Now, just imagine using that kind of technology in health. And I think the National Digital Health Mission is going to address some of these to ensure that the framework is created. Travel, for example, also is so precise. You print your boarding pass, you set your seat, and you just catch your flight, and everything is done so well. But health, we're lagging behind, and I'll give you a perspective from a research, a healthcare delivery, and an educational platform. So in research, yes, we work in silos, again in research, but we need to capture data. So we have robust data capture systems, whether it's clinical trials, whether it's basic sciences, we use data capture systems. We use different analytical systems. We have various statistical applications. We have bioinformatics systems, all very well, but in their silos. You try and get them to talk to each other, they fail. Same with the healthcare, other panels have just described. There are silos. Large public health data systems, there are EHRs, etc. There are small practices as well using systems. And of course, now you have pharmacy chains having systems. You can walk into most of the big pharma chains, and they all are connected. On the educational front as well, there are e-learning systems. several startups, as well as there are homegrown systems, there are open source systems, but do they all talk to each other? No. But in reality, you know, healthcare delivery and patient care, research and education are a continuum. They all feed into each other. How do we do that? And I think going forward, I think the National Digital Health Mission is going to address all these. Just to go back to some of the facilitators that help catalyze this and what are the drivers, there's an increasing awareness from most healthcare organizations, big or small, that you need to do this. One is saying, okay, they are doing it, let us also do this. And there's an increased adoption, although not to our expectation. There's a felt need sometimes to improve efficiency, to reduce cost. Many hospitals deploy these systems because they want to cut leakages. You know, there's pilferage, etc. So they deploy healthcare systems. And from a financing and insurance perspective, although very small in India, of course with the Ayushman Bharat, that's going to become a major aspect of ensuring that you have accurate data to provide benefits to actually much larger populations. Some of the other drivers are reducing costs in IT itself. Earlier things which were not affordable are today affordable. So even smaller hospitals are willing, or smaller clinics are willing to spare some money to digitize. There is a willingness. There's also a drive from the quality angle. People want to do it because they want to comply with NABH standards or NABL standards or their own internal standards. And of course, as we just heard, the governance and government efforts are drivers. The National Digital Health Mission is going to be one big driver. I recall the HR standards which were developed right from 2010 and then finally released in 2016 by the Ministry of Health was a wonderful guidance. And I'm sure that which Mr. Satyanarayana just mentioned, they've refined that, distilled that, and taken that technology, the core aspects of it. The EHR standards were very vast. And of course, there's several other initiatives by the government, including on the learning side and education. They've subscribed to Cochrane, for example, for the whole country. Cochrane Library, which is an evidence-based database. There's SNOMED CT. The government has already subscribed to many of these terminologies long time ago and made it freely available to any software company who wants to put in standards where data can talk to each other. The barriers are much more. When we talk about barriers, Sunita just mentioned, and Mr. Satyanarayana mentioned, we're not designing our systems to protect privacy. Most systems are just designed to keep in mind, a certain aspect that we're trying to solve. User sensibility is not taken into account, and that's usually the big pushback across stakeholders. And when you probably talk on the sidelines to healthcare professionals, they'll probably tell you the doctors are the biggest people who push back. And yes, sometimes you should listen to their argument. Yesterday we heard them. Some of them saying, I see 100 patients in 4 hours. I get to interact with the patient about 2 minutes or less than that sometimes. You put a computer in front of me, do you expect me to chart? And these doctors are saying, we have algorithms running on our head trying to figure out what's wrong with the patient. The moment you put us into a well-defined form, you want us to chart in that form, we're going to lose our eye contact, we're going to lose our flow of thought, and we're just forced to think as the machine is pushing us to think. And some of these are challenges, barriers, so we need to address these. Data standards, most IT systems deployed across the country today do not have data standards. Although we have SNOMED CT freely available and there are other standards available, very few of them have adopted this. Likewise, one of the questions managements ask IT departments is, what's the ROI, return on investment, if I deploy this technology? And really, there is no ROI. The ROI is improving health. It's a very broad ROI, if you ask me. Data privacy, I'm sure Rahul is going to address this, but we spoke about that. Privacy has to be by design. There are some fantastic systems that I've come across where these are actual systems, and a group in Wales has been doing this, where you actually anonymize at the point of collection of data, so that your data is kind of protected and the confidential data is held separately. We need to think of such technologies. In research, we do it by default. We have to anonymize as we go forward. But in clinical practice, doctors need to know who that patient is, so that's a little complex. So these design issues have to be taken into account. People, technology, and processes have to be kept in mind. One of the challenges, we don't understand workflows. We go and deploy a system without understanding the clinical workflow, and that has its own disadvantages. So understanding workflows, mapping data, mapping the needs, and ultimately keeping user sensibility in the whole big picture is important. So that's my perspective about barriers. I think going forward, this federated architecture is wonderful. It'll be too disruptive to tell everyone to change their system or tell everyone to use one single system. Trying to see, can we have an interoperable system? Today we are so used that we can go to any ATM and put our card and we'll know we'll get money. Irrespective of your operating system on your phone, if you send a WhatsApp message, it gets across seamlessly. Can that happen in health? And I'm sure the light is shining at the end of the tunnel. I'm so pleased to hear this about the National Digital Health Mission and looking forward to seeing how things pan out.
Thank you very much. That was precisely 10 minutes. Thank you. Rahul.
Okay, I'm a lawyer, so you've put me in front of a mic. You'll have to stop me speaking. I'm the lawyer, and so after all the sunshine, I'm the rain. Whenever you talk about data, whenever you talk about personal data, the thing that comes immediately at the side of that is privacy and security. And I've been doing this for some time. When I first met Sachit was 2015, and at that point in time, no one was speaking about privacy. Today, every person that I speak to in government, outside government, the only thing they talk about is privacy. The reason why that happened is because from 2015 to now, there have been 3 watershed incidents that have changed the way in which we all think about privacy. The first was the right to privacy judgment, the Puttaswamy judgment, which clearly articulated that every person has a fundamental right to privacy. It doesn't matter that it's not written in the Constitution as a fundamental right to privacy, you have it. And that the government can only violate that fundamental right to privacy through a law, which must be responsive to a state need, and the actions that you take under the law must be proportionate to that state need. So that's a high barrier. Within a year, that 3-4 test was applied to the Aadhaar project. The Aadhaar project passed through the test, but I wouldn't say it sailed past that test because its wings were significantly clipped. And at the same time, while all of this was happening, Justice Sri Krishna came out with his draft report for a draft privacy framework for this country. Now, this is actually the 3rd or maybe 4th draft of a privacy law. That draft was tabled before the government, but didn't make it. The government didn't have the time to pass it, and I think it's something that needs adequate time to think about, so perhaps that was for the best. But I think as we talk about what we're going to do in digital health, it makes sense to use that as the framework of what the law is likely to be, and therefore what issues we should be thinking about in the context of framing this. And I'm very happy to hear suggestions that seem to be coming out in the Digital Health Mission that are very privacy focused. But I'd question some of them I'm questioning it without having read it, so maybe they've thought about it, but I'll just question 2 or 3 of them. The first is, based on the Sri Krishna report, it seems that we're going down a notice and consent driven privacy framework. And I question whether consent is as useful today as it might have been when we first thought about consent in the framework of privacy. It's not that we can't, not that you can take my data without my consent, but just think about it. All of you've got smartphones. You've got maybe, if you're me, you've got 300 apps, but you may have 50 apps. How many of you have read the privacy policies on those apps? Because you have to have consented to it before you accepted it. And even if you did read it, if it was WhatsApp, you would have consented to it if you didn't like it, because all your friends are on WhatsApp, and so you can't survive in today's world without WhatsApp. So we have two things. We have forced consent because we have to consent to participate in this world, and we have consent fatigue because we have so many apps asking for our consent that we just say yes to get over the damn thing and carry on with life. Second thing is, today our databases are connected to each other. So even if you gave consent in the context of one database and understood that, gave consent in the context of another database and fully understood that, did you understand what that consent would mean when the databases were connected? We can't. It's not possible. And on top of all of that, we have AI today, which will build profiles out of non-personal data, just because AI has the ability to connect the dots in a way that humans can't. And so in that context, if we rely on consent with nothing else, we are going to have a problem. The second thing that Sri Krishna talks about is purpose limitation and use limitation. Now, one of the benefits of having a lot of data in the medical context is that we can use that data for research. But if you have a law which says that you can only use the data for the purpose for which you collected it, which is what the GDPR says, what our draft law says, and that's the way in which we think about privacy, then you cannot use that data for any ancillary purpose. And one of the reasons why we are all celebrating having all of this data is because we could use it. We could run AI algorithms on it and find the cure for cancer or whatever else. That's the hope that you hold out. But if you go down this route, you may not be allowed to do it. And then the third element that's there in the Sri Krishna committee, these are global standards on privacy. The third element is data minimization. And it says that you should not collect any more data than you actually need. Now, if you want to train algorithms, machine learning algorithms, large neural networks, the only way you can do that is to throw as much data as you can at them, such that they can find those patterns. How are you going to do that if you've got an obligation for minimization? I heard the earlier panel, and I was, not being a scientist, I was really moved by statements like critical thinking. We don't do any critical thinking in the law. That's because the common law system requires you to operate on what we call precedent. You are obliged to, your next step must be in conformity with the step before that, and all the steps going back centuries maybe before that. We're path dependent. And as far as privacy is concerned, we are going down a path dependent route. We're copying from the rest of the world what the rest of the world thinks is wise, and not pausing to think whether in our context, and not only in our context, but in the global context where we don't have the baggage that the rest of the world has had to have. We have the ability to chart our own path as far as privacy is concerned. We're not stopping to think about that. Instead, we're blindly copying the law that the rest of the world is forcing down on us, and I question whether that is the correct path. If I have time, I'm going to... 2 minutes 45. I'm going to make it. Because I don't want to be only, rain. I want to be some sunshine as well. And there are things about the Sri Krishna report that are actually quite remarkable. The first is data portability. They have a provision in data portability in the law which is called data portability, which is unique in the world. Around the world, you have this concept of portability, which essentially means that you can now ask Facebook to port all your data down. So Facebook has to give you a data dump. If it's me, it's about 500 megabytes. If it's my wife, it's about 5 gigabytes. And you get all your images or everything that you said, the videos, and it's all in one nice little file that you can read. Facebook does it really well, so you can actually read it. Others just give you a dump, which is quite difficult to use. But we are required in our law to do it in a machine-readable format, which means data portability in India is actually designed to port from one system to another, which is why some of the things that are being talked about in the National Digital Health Mission are powered by that. And that's really good. The second really remarkable thing about this law is not new, but it's the concept of privacy by design. Privacy by design is a concept that was talked about by Anne Kevorkian, the Canadian Data Commissioner, and it essentially says that the default situation in your app or in your system has to be privacy. And you have to force users to want to turn it off, as opposed to giving them a non-private solution by default. And I'm really glad to see that there are provisions in the National Digital Health Mission that seem to acknowledge that. I think Mrs. Satyanarayana actually spoke about it, privacy by design, and that's really the way we need to go. One of the powerful legs of privacy by design is anonymization by default. And if you can actually implement some of the things that Professor Tony just mentioned, which is anonymize the data as soon as possible, you've actually made that data much safer than it is otherwise. And the third thing is not in the Act, but it's something that we've noticed the government quite willing to do in the financial services sector. In fact, the governor of the RBI announced it a couple of weeks ago, and that's the concept of regulatory sandboxes. When we work in a digital world where everything we do can be observed and measured, we have an obligation when we are making policy to evaluate the implications of the policy. In a non-digital, non-measurable world, it's actually very hard to do. But when everything can be measured, one of the solutions is to create a small sandbox, limited number of people, limited geography for a limited period of time. Change the laws for those people and for those contexts and observe what impact it has. Then you can decide whether to implement that law, decide whether to implement different laws or not to do it at all. Our policy making is going to be that much more robust if we do something like that. And it looks like the government of India, at least in the financial services sector, is keen to do it. So I hope we think about doing that as well in the health sector.
Thank you. I'd like to thank all four of you for very, very compelling talks, all very diverse, shedding a different light on this very complex topic. We'll follow the rules that preceded us, as we must, as you hinted, and open up the mic first to 31 and down. Please.
Yeah, I have a basic question regarding how big data can help India's, problem regarding its physical infrastructure. For example, during monsoons we see, doctors, finding it really hard, to, work out solution for the patients. On the one hand, they are not able to cater to the tier 2 and the rural areas. On the other hand, in the urban centers, where we are seeing, that they are getting, patients are getting completely, fleeced by these big pharma companies, big insurance companies. So how big data can really bridge that gap, and can maintain certain kind of standards,
So how will big data protect the patient from monsoons?
Well, that's a difficult question. As I just articulated earlier, there are challenges at the doctor's level itself in collecting, data, charting data. But yes, if you have large volumes of data and data that's clean, you could look at patterns of diseases. Let's say we've deployed a system for ICUs, but I think in the US, MIT has set up a system called Mimic, which is a huge anonymized data set in spite of all these stringent laws. They have millions of data points. Just take, for example, everything related to a patient anonymized is captured there, from the blood pressure dropping to the drugs that were given. Now, just looking at this enormous kind of data, if you actually run that through big data analytics, you will see patterns emerging about certain conditions. What procedures did you did that saved a patient's life? Same patients, similar symptoms, similar comorbidities. What were the interventions that helped save a patient's life or not? So these patterns will emerge from big data, because that's how these engines are designed to pick up unseen, things which are otherwise invisible to human eye.
If I may also respond to you, you have a point that is very important to recognize as we get onto this data and technology bandwagon, right? Because if you heard the phrase Sunita use, she said, enabling technology. Technology amplifies
amplifies the things that work and it amplifies the things that do not work. And where it comes to medicine, I welcome the panel to respond to this as well. Over 100 years ago, Foucault said that medicine is politics by other means. The inequities that you see in medicine as a reflection of the society that we build around them. And so your question is very well taken. And I think we have to be very conscious as we adopt these technologies to see whether they are going to help decrease the inequities or are they just going to make these gaps wider. Can I have another question, please? Yes.
Yeah. You can use this. Yeah, hi. So I just want to carry that analogy we started, that there is a migrant female labor who she's pregnant and going from state to state. Now the question is here that some hacker is sitting between a physician's app and the tower. Now, by using electromagnetic waves, he can manipulate or steal complete data. Let's just assume for imagination purposes that the migrant labor dies. Now, who all are involved? The labor is involved, doctor is involved, hacker is involved, service provider is involved. Question is, who is responsible?
Sounds like a legal question.
Who's paying?
These are the kinds of questions I love, because it's going to take me many hours and many billable hours to solve. But really, I think the point is you're absolutely right. Technology today is hugely complicated. And if we apply traditional standards of remoteness, of damage, traditional standards of ascertaining liability, we're not going to come up with an equitable answer. And even as lawyers, we've got to think about this differently. Clearly, we can't hold the cell tower liable because the cell tower has got no way to know that the way it was hacked is going to result in someone dying. I don't know if we can hold the NEHA or whichever the health authority is liable. It's actually, these are one of those situations where, unfortunately, we're going to have to, after the fact, find some way in which we create regulation to prevent this from happening. But I can't see any simple answer for that.
Back there. Yes.
Good afternoon, sir. So there was a question regarding that you talked about the data minimization. So I would like to know that while searching for any data, there are many things that are already downloaded with along with us, and along with that there are files also that gets downloaded. And even after deleting those files, there are some shortcuts that usually stays with us. So how can we remove them as well?
So the
interpret that in terms of health data.
The principle of data minimization is that you must collect as little data as possible when you collect it. So if you think about in the health data context, if you're actually going to treat a particular simple ailment, don't collect data about everything under the sun if that does not pertain to the actual treatment that you're going for, or if you're a particular vertical within the government, only collect the data that you were supposed to collect. Don't collect everything under the sun.
So, but how can we know that?
No, we don't have the luxury to have a conversation. We started exactly an hour ago. We have time for one last question.
But
the lady
we have
by
a
the
small
door.
comment.
Hello.
Like if the data minimization.
I'm sorry. Let me call on people, please. Yes.
Good afternoon,
the lady by
everybody.
the door, please. Yeah. In blue. Yeah. And that'll be the last question.
Hi, I'm just interested in knowing if there's something specific that's being done about mental health at workplace.
Well, mental health is one of the packages under Ayushman Bharat's health and wellness centers. Not necessarily looking at workplace, but it's one of the 12 packages that are going to be now universally provided free of cost to every individual under Ayushman Bharat health and wellness centers. Yeah.
I see a lot.
The guidelines are just being drafted.
There are a lot of hands up, and we'll hang back and happy to discuss with you during the break, but we have to move on. We started 6 minutes late. We're ending 6 minutes late, and we'll end here. Thank you very much, all four of you, for your time.